Welcome to ADAPT NCLEX, and thank you for deciding to watch this video. You know, for the NCLEX, the new generation questions, you don't know what kind of case study you will get. You may know something, but the way they will put it in the case form, you won't be able to figure out. So I decided to make this video. I think you would like to watch this. It's a very interesting one in a case form, about 11 questions. But just to go through, break down each case. It's a practice question, so you can take it multiple times. But this is a video. If you want to take the exams, you should watch before you do that. So let's get to it. Short case, as usual, you have to recognize the buzzword, which is the main thing for the test before you can answer any question. So what is the problem? A 50-year-old male is a buzzword, present to the PCP with complaint of what? Intermittent mid-epigastric pain. He has dyspepsia, diaphoresis, and fatigue when going up the stairs. This is a form of exertion. So when he's exerting himself, he has pain, diaphoresis, and fatigue, and doing guarding work, buzzwords. Those are all exertional chest pain, right? Symptoms last for a few seconds. That's your clue, and is relieved by rest. Occasionally it comes up with the problem, the pain. It came in because his symptoms are what? Becoming more frequent. He's worried about it. It's getting too much. Client has history of diabetes, hypertension, hyperlipidemia, and GERD. These are his risk factors. Never had any surgery before. He denied tobacco, alcohol. He's on appropriate medication, metformin, lisinopril, meprazole, and atorvastatin. Vitals, ephedra, heart rate is like 110. Blood pressure elevated, and SATs 98. S1, S2 present, and the rest of the exams is normal. What are your buzzwords? Which words, when you hear it, you should worry about? Intermittent. First, age is a clue. Intermittent mid-epigastric pain in a patient who has diabetes, right? I have diabetes, mid-epigastric pain. We feel like reflux, but this is a distractor. It's not reflux. This is his chest pain. It's dyspepsia, feel like reflux, but that's truly chest pain. And it's shortness of breath, and sweaty, diaphoretic, with fatigue. All this when he's doing what? Going up the stairs. So when he's exerting himself and doing guarding work. So exertional chest pain, which is described as dyspepsia, diaphoresis, fatigue, and epigastric pain in a diabetes patient, is MI or angina. Is having angina kind of chest pain. So you have to worry about it. So those are my buzzwords. And the symptoms is relieved by what? Rest, another buzzword. Occasional relief by times is a distractor. Symptoms are becoming more frequent. These are worrisome, but it's not a buzzword. That means it's getting more frequent. So whatever angina is getting is now having unstable, and it's getting bigger, and more frequent, even without exerting himself. His heart rate is high. His blood pressure is uncontrolled. He has all the risk factors. So the buzzwords: age, dyspepsia, diaphoresis, epigastric pain, fatigue when he exerts himself, and relieved by rest. Those are my buzzwords. And that indicates to me that this patient is having chest pain, is having some angina, and it may be leading to myocardial infarction very soon. Okay, so that's the way they will present the case, and you have to figure out what you need to know. So that's the buzzwords. Okay, but you have to go with the question they will ask you. Okay, what are your priority findings? We already seen it. Priority findings are findings you need to follow up on. Okay, exertional chest pain. Yeah, so those are exertional chest pain is my priority finding. And then the symptoms are what are getting worse and worse and worse. That's why you came in. Those are my priority findings because the symptoms are getting worse and it's getting exertional chest pain. So those are my priority findings for this particular case. It's the same case. I just repeated it from the other side, the same case. So his symptoms are becoming more frequent. That's one. So more frequent. He has exertional chest pain, and his vitals normal 3 and his blood pressure 4. So this is a problem. This is a problem. Symptoms becoming more frequent and exertional chest pain. Those are my priority findings. Okay. Now, what is the next anticipated diagnosis and the plan of care? This is not reflux, even though it's relieved occasionally. The word is occasionally. It's not truly. You don't have pain by resting. Your pain doesn't go away by resting if it's a reflux. So this is gone. There's no evidence of pancreatitis. He said he does not even drink. So there's no alcohol related. This is an angina, chest pain. He can be moving from a stable to unstable. This is not pericarditis because the pain will be relieved when he leans forward. Leaning forward will relieve the pain. So that is gone. This patient saw his primary care doctor in a clinic. I think it's appropriate to send him to the emergency room for a workup because there's so much you can do in the ER than in your hospital, in your office. So I would send this patient to the primary care office, from the primary care office to the emergency room. They will need an EKG. They will get a cardiac enzyme to figure out what is going on. And probably they will consult a cardiology. All this is interrelated, test-taking skills. If I'm getting EKG, I have to get a cardiac enzyme because I'm looking at the heart. If I see anything abnormal, I have to call cardiology. So angina is the diagnosis. You need to go to the emergency room. You need to get an EKG, cardiac enzymes, and then cardiology maybe consulted. Okay, so number 3. This is what you got. EKG results shown below. You get an EKG. What is your diagnosis? First degree heart block, A-flutter, AFib, supraventricular tachycardia. When they give you a rhythm like that, look for the rate and make sure the rate and rhythm is sinus. R is where you can find your rate and the rhythm. I'm looking at it. I can see from here to here, it's not the same as here to here. From here to here, it's not the same. So I don't have a sinus rhythm. If I don't have the sinus rhythm, supraventricular tachycardia is gone. A-flutter is gone. In the first degree heart block, what do you think? The PR interval increases. There's no drop. So this is also a sinus rhythm. So first degree heart block is just the PR interval. I see the P here is long, but here is different. It's different. The PR interval is not constant. It's changing from place to place because of the AFib. And therefore, it cannot be first degree. First degree heart block, the PR interval is greater than 0.2, okay, seconds. But it's constant, it's true. It does not change. Therefore, it cannot do this. A-flutter, you're looking for saw-toothed atrium function. I don't see any saw-toothed here. There's no saw-toothed. This is the flat atrium. AFib, I see irregular rhythm, right? And I cannot even discern the P wave. You can't discern the P wave at all. It's just like you can't see them. There's no, this is T wave. You can see the P wave. So you can't discern any P wave, and the rhythm is irregular. It's atrial fibrillation. Supraventricular tachycardia has to be sinus, and the rate very, very high. So this is atrial fibrillation. What is your priority intervention? When somebody has AFib, there's two things you have to ask. Does the patient have symptoms? So this is what you do. Did you have symptoms or no symptoms, right? If they have symptoms, then you got to do something faster. You got to convert the ventricular rate back to sinus right away, right? You got to bring it back to sinus. And what you do is cardioversion. When they have symptoms, that means they have dizziness, they have diaphoretic, they have hypotension. This patient doesn't have one right now in the emergency room. He does not have any. The only thing he has is hypertension, right? And a heart rate of 110. But when he came to his primary care doctor and he complaining. So he has no, I've not given you that the patient is symptomatic. So if they have symptoms, you have to convert the ventricular rate into sinus and then do cardioversion. If they have no symptoms, yeah, you have time to just convert, lower, decrease, or control the ventricular rate. If it's 110, you want to bring it to less than 100. That's all. That is the best way for AFib. AFib, you want to control it, bring it down to less than 100. So that is the ventricular. And what is the problem? Okay, so let me, I will explain it later. So the ventricular rate, bring it down as much as possible to 100. That is what you do. This patient has no symptoms. Okay, so I need to convert the ventricular rate down to 110, down to less than 100. I can use anything I want. I can use calcium channel blocker. So look at your answer choice and see if there's a calcium channel blocker. You can use a beta blocker. It's fine. You can use the digoxin. Okay. You can use what? Amiodarone. All these things can bring the rate down. They're going to bring your rate, lower your rate as much as possible. Anticoagulation is not your priority intervention. Why? When you have atrial fibrillation, this is the reason why. The atrium is quivering. It's not contracting the way. So the rate can go into like 200 to like 300, the atrial rate. The ventricle has to pick it up. So the ventricle will decide if you want to pick the 200 or the lower one, the one we saw, 110. If the rate is a little bit lower, like we see, yeah, you need to control the rate, right? Even if it's higher, you may control the rate or do cardioversion because 200 will be too high. Most of the time, if your heart rate is too high, you don't have time for medication. You have to consider that as symptomatic, right? This is, if you don't do that, what will happen? If the ventricular rate is too high, patient will become symptomatic, hypotension. If your ventricle is pushing so fast, only small blood will go. So that's the main reason why. In order to prevent patient from having symptoms, the priority action for AFib is to rate control the ventricle. You want to just control the ventricular rate, and that is the most important. That's why you give them something to control the ventricular rate. They will develop some clot. If the atrium contract for over 200, that means the blood will clot over there, and then it will emboli. This is the reason why we give them anticoagulation, but it's not the most important. The most important is rate control. Therefore, warfarin is not a problem. The thiazide is a calcium channel blocker, I said. Nitro will decrease the blood pressure, is a venodilator. Marinol is also a venodilator. So rate control is this. This medication you have to know: calcium channel blocker, beta blocker, digoxin, and amiodarone. Okay, rate control is the best priority intervention. 3 hours in the ED, patient report of what? Dizziness. He's in the emergency room. Now he has dizziness, diaphoretic with a heart rate of 110. This is the rhythm. It's the same rhythm we saw. It's AFib. What is your priority action? Now I have a patient who is symptomatic. What would I want to do? Do I want to control the patient rate or do something better? That is what we discuss. I now have AFib and I have symptoms. Well, I just need to prevent hypotension. I'm symptomatic because the ventricle probably is picking up. That's why. So I need to now get me out of that symptoms quickly. We need to stop the symptoms. Warfarin will not stop the symptoms. Amiodarone may, but it's not your best choice. Defibrillation kills the patient. You don't defibrillate AFib, you do cardioversion. So that is the most important. So with patient who has AFib and symptomatic need to be cardioverted, synchronized cardioversion. Okay? So that's the treatment for that. That's your priority action. Rate control is not a problem now. Now we want to change the rhythm back to sinus. Converting cardioversion is converting the rhythm back to sinus to prevent the hypotension because the patient is symptomatic. 3 hours in AED, patient report of what? Dizziness, diaphoretic with a heart rate of this. EKG shown below. Cardioversion was performed, like we said. Why should the sync mode be on for this rhythm procedure? This you have to know. We always say put the sync mode on. So this is the atrium and depolarization, the ventricle coming, and the T wave, and the atrium start again. So this is P, this is Q, this is R, this is S, and T. When you're synchronizing and with cardioversion somebody, you want to shock them on this, shock on the R wave. The only way you can target the R wave is to synchronize the defibrillator. If you don't synchronize, what will happen is when you shock, it end up being on the T wave. If that converted to R on T, if that happens, patient will go into VTAC and pulseless VFib, and they die dead. This is a lethal rhythm. You're converting AFib to VTAC, that's deadly. So AFib, I would take AFib over VTAC or VFib. Therefore, to cardiovert somebody, most of the time when you cardiovert the patient, they are awake. To cardiovert the patient, you need to put the sync mode on, synchronize it to the R wave. Synchronize it to the R, no R wave, the R portion of the QRS, not the T wave. If you don't synchronize, you shock them on T wave and they go into little rhythm. If the examiner asks you why you should do that, number one, you said not necessary. There's a reason why they're asking you. If they ask you, then you're saying not necessary to have the sync mode on. This is a test-taking strategy. You should not pick his answer. You say, why should? That means there's a reason why. You need to put the sync mode on. Now you answer choice, not, I'm not looking at it. Deliver appropriate voltage. It has nothing to do with the amount of voltage. To shock on T wave, no. When you shock on T wave, you causes a lethal rhythm. To shock on R wave of the QRS, excellent. To prevent R on phenomenon, right? R on T phenomenon. So 4 and 5 are right. We want to prevent R on T phenomenon. This is the reason why we shock. So to shock on the R wave on the QRS and to prevent R on T. That's something you should know. Why? Patient underwent immediate synchronized cardioversion successfully. Heart rate is now 80. So now it's back in 80, right? Echo is shows what? At 48 hours later, show no thrombi. So there's no thrombus over there. What is the next best action? This was the original rhythm. I just put it there so that I know this is what we're talking about. We're talking about a patient who has AFib. Now it's being cardioverted. So it should be in sinus. But just to refer you back to the old. Now somebody who's being cardioverted, and you get, that's the clue. So they come in with AFib. This is the teaching. You control their rate, or you cardiovert them. And when they're done, you get an echo to make sure there's no clot in the atrium. Then you start them on what? Anticoagulation. Okay? We should not continue. It's not that important. Continue the thiazide. Yes, I mean, they will still be on some form of rate control, right? Nitro patch is not going to help you. Amiodarone, we're talking about rate control. As soon as you see echo, the scenario has changed and there's no thrombi. We've already rate controlled them, cardiovert them. We need some anticoagulation. Somebody would say, well, you still have to pick this. Well, there's two answer choices there, you know. It's not necessary. They will be on them, but that is not the next best action. Continue diltiazem is not your next best action. Adding amiodarone is not your next best action. Your next best action is to provide them on anticoagulation. This is the test-taking strategy. We already know the cardiovert. They're going to be on some form of rate control. Every time you see continue, you're doing nothing. Test-taking strategy. Watch my video on test-taking strategy. And nurse has to do something most of the time, 99% of the time. So do something. How about that? Do something for this patient, and then the patient will be happy. Okay, so we need to put the patient on anticoagulation. That's what we need. Number 9. The cardiology recommended cardiac catheterization, keywords, due to the ongoing chest pain despite cardioversion and being rate control. So there's a bunch of words there. So cardiology said the patient need catheterization, okay? After we do what? Cardioversion. And we put the patient on rate control, right? The cardiac catheterization show what? Severe 3-vessel disease. What is the next anticipated best action? So this is your heart. It has vessels that supply. There's a 3 main one, okay? I don't need to mention the name. I'm not going to mention the name. When you give you a test, they will use the word coronary artery. And there's a left, there's the right, circumference, it doesn't matter. So 3-vessel disease, the main 3-1 is all diseased. What do you think? That's why they're still having chest pain. You want to put a stent in vessel disease that is so severe. You want to continue aspirin. You want to continue anticoagulation, and you want to do CABG. Which one you want to do? Which one do you want to do? Whenever somebody have 3 severe, when they use the word severe vessel disease, there's nothing you can do than surgery. Usually, if they have 1 disease, if you have 3 and 1 is not good, yeah, sometimes we try to put a stent in to open it. But if all the 3 are non-functioning, yeah, we got to do something better. Otherwise, patient will have a heart attack. So cardiac stent is not an answer. Aspirin medication will not solve it. Anticoagulation is also medication, will not solve it. we have to take the patient to CABG. So anybody who have chest pain with severe coronary disease in all the three vessels needs some form of surgery, and that is CABG. Okay, so that is that. That's our answer. Now, I didn't want to give you the answer, so that's why I left it. The client asked the nurse about CABG, CABG. Which of the following is consistent with the procedure? What is CABG? It's a coronary. It's a surgery that we do basically to restore blood flow to the heart. So if this is the heart, these vessels are diseased, right? We leave them there. We don't go and take them. They disease, you cause more problem. So what we do is we go to your leg, okay, and take a vein. And vein, usually we call it saphenous vein. We take the vein from your leg, so you have incision in your leg, and we take this vein and we use it to reroute blood flow to your heart. We connect this to a vessel that runs through your chest, and that reroute and provide blood flow to the heart. And so that's why it's called coronary artery. The artery we are bypassing with the graft. The graft is the vein. Okay, sometimes, most of the time, they try to use a vein. If they cannot use a vein, then they have to use artificial graft, basically, to do the procedure. You know, like a stent, not a stent, but different kind of material that is designed to do the same thing as the vein. But they always try to use your innate vein. So we're talking about a saphenous vein that is taken from your leg. So there's going to be incision on your chest. We go into your chest and then do the bypass. When we finished, we close the incision. You're going to have a chest tube. So you have incision in your chest and incision in your leg, and we take care of you. So the meaning of CABG is coronary artery bypass graft, using the vein to reroute your heart. That's all. Used for very severe coronary disease, not amendable for stent. Yes. If the stent, we don't think stent will work, that's wrong. And most of the time, patient has a severe disease. It's the same as coronary artery angioplasty. Angioplasty means I go into the vessel and I break the clot and I put the stent there, which is the same as this. No, it's not the same. You don't go to the vessel anymore because the vessel is diseased. So you want something better, so you use a vein. We're not going to try to repair the angioplasty. If you see angioplasty, it's the repair of the artery. The angio is the vessel, plasty is repair. So I'm going to the vessel and breaking all the clot and trying to repair it. We are not doing that. We ignore the disease artery and bring a vein as an artery to provide blood supply to that. So this is right. Used for severe disease, but this is wrong. It's not the same. Require incision in the abdomen. No, the incision is in the chest. We go into your chest. You will have chest tube after the procedure. Yeah, every time we do a procedure that has to involve the chest, for a heart problem, you need a chest tube to drain the heart and the fluid around the heart to prevent a problem called cardiac tamponade. So we'll talk about that. A vein will be harvested from your leg to replace the diseased coronary artery. Yes. CABG, when they're doing the CABG, because we're going to work on your heart, we're diverting blood flow from your heart to a machine. The machine will have oxygen put into the blood, and then they send the blood to the rest of your body so that the rest of the body doesn't die, but your heart doesn't receive any blood anymore. So that is what we call cardiopulmonary bypass. So blood will be diverted from your heart using a cardiopulmonary bypass machine during the procedure. So this is true. So this is everything you need to know about CABG. It's called coronary artery bypass graft. Okay, we use it for severe coronary disease that we cannot put a stent or medication. It's not the same as angioplasty. You have incision in your chest. You need a chest tube. We take the vein from your leg, and we have to bypass your heart while we're doing the procedure. After that, we let your heart receive the blood. So that is that. Number 11. The client underwent successful CABG. Which of the following the nurse should monitor for after the procedure? This is your heart. We provide more vessel. I told you you need a chest tube. The chest tube is going to drain blood around the heart. If there's a blood around the heart, what medical problem do you know that anything that we have blood around the heart, what problem does it cause? It causes what we call cardiac tamponade. Because of that, we prevent that, and we have a chest tube to prevent that. Therefore, the nurse should be monitoring the chest tube output. If there's no output, we worry about it. We want to make sure there's something draining. Okay, so monitor the chest tube output. Okay, incision for infection. Yeah, there's incision in the chest and the leg. Muffled heart sound, what do you think about it? Narrow pulse pressure, what do you think? Pulses paradox, JVD, and hypotension. These are all signs of tamponade. When your heart cannot pump because the blood is squeezing your heart, the heart sound changes, it becomes muffled. If the heart cannot pump, okay, you have heart failure and you have JVD. If the heart cannot pump, then we have hypotension. When these happen because of the congestion of the heart, when you take a deep breath, inhalation, when you take a deep breath, your blood pressure decreases. This is what we call pulsus paradoxus. Blood pressure, systolic blood pressure, decreasing when you take a deep breath is pulsus paradoxus. When your heart does not pump and is being squeezed, your systolic blood pressure get closer to your diastolic blood pressure. This is what we call narrow pulse pressure. So all this is what we call cardiac tamponade. The Beck Triad, usually hypertension, JVD, and muffled heart sound. Beck Triad, yeah. Muffled heart sound, okay, JVD, and hypotension. These are what most people know. Hypotension, JVD, and muffled heart sound is cardiac tamponade, Beck Triad. But I want you to also remember narrow pulse pressure and pulsus paradoxus. You'll be ahead of anybody who just know 3 because sometimes they put more options and you don't know which one it is yet. Narrow pulse pressure and pulsus paradoxus is a form of cardiac tamponade. Is part of the 5 pentad of cardiac tamponade, but most people talk about the triad. That's called the pentad. Okay. Now, finally, last one. Sorry, long, but very high yield facts. The client did well after surgery and ready for discharge. Which instruction from the nurse is appropriate? Now they want to go home. Which instruction is appropriate? Do not submerge the wound under the water for 6 weeks. Whenever you have incision, surgical incision, especially high-risk incision, high-risk, that means they can get infected or diseased. You should not put it underwater, submerge it underwater. That means no shower. You sure? No. No bath. So that's a trick answer because people always get confused with that. If the water is going to, if the incision should not be underwater, then no bath for 6 weeks. But you can shower and you can pat dry the incision, just pat it after showering. So this is good. Avoid lifting anything 20 pounds. Yeah, any high risk incision, abdominal incision, big one, and a chest incision, you should not do heavy lifting until instructed, and 20 pounds is minimum. Enroll in cardiac rehab program. Yeah, your heart needs to grow and get better. Resume sexual activity as desired. No, you don't. Sexual activity is an exertional problem. You have to exert yourself. You're involving in cardiac rehab because we want to make sure when you're exercising, you don't get chest pain. Well, if you go and have sex without the doctor monitoring you and telling you you're ready, you're going to have chest pain and then you have a heart attack. So anybody who have CABG should not start sexual activity until instructed by the doctor after a couple of cardiac rehab to make sure your heart can take the stress of the sex. So this is wrong. Continue to take all your medication. No brainer, right? Call the clinic with any concern about the incision. No brainer. So these are some of the teaching you give to somebody who has coronary bypass graft. It's classic, and you have to know that. This is the case using AFib and CABG in a patient. In one case, to show you next generation cardiology, a comprehensive review. Thank you for listening and going to the end. And thank you for subscribing. If you have not subscribed, subscribe and put your notification on to get more content like this. All the best of luck and good luck in your exams.